Hi, Nikolay. Hi, Mehmet.
Oh,
Good to
hi.
see you guys.
You hear me? You hear me?
Yeah, I can hear you very well.
Excellent, excellent, excellent. Glad to see you. So, how many people will be in this webinar?
So basically, we have had from 55 to 250
Okay.
people attending.
Mostly
So
spinal surgeons.
Mostly spinal, and majority are trainees, actually.
Trainees. Okay, so well, to talk more about for trainees, yes. Okay.
Yep. Mehmet, can Nikolay?
No, actually, you are the moderator. You should do that. I'm staying on site. Please
Okay,
manage.
brilliant.
It-
Dear friends,
there
I
are
welcome
almost
you.
2 more minutes.
Okay, at the moment we have 38 participants and we are building. I welcome you to this WFNS Spine Committee. And
how many participants we have?
At the moment we have 40 now. They're just growing, they're coming.
Yeah.
So it's 41 now. So yeah, so I welcome you to this WFNS Spine Committee webinar. And this is also supported by Pakistan Society of Neurosurgeons. Professor Zalili has been very kind in organizing these webinars for a long time, and we are grateful to him. And today we have a very distinguished speaker, Professor Konovalov, who's from Russia. He's a world-famous neurosurgeon, has done a lot of interesting things. Just like his dad, he's taken the torch forward and has done some amazing work. He's going to tell us, and we requested him to keep it especially for trainees so that they can learn from this and take it away with a lot of enthusiasm. And I think welcome, Nikolay. It's a pleasure to have you here.
Thank you. Fantastic. Very good. Very good.
Please start. Go. Yeah.
We ready to start? Okay. Hi everybody. Yeah. So I need to put on my PowerPoint presentation. Yes.
And you must share the screen.
Okay, I share the screen and now we do. So I'm going to talk about modern aspects of minimal invasive spinal surgery using intraoperative CT and navigation systems. So I'm present shortly me. I'm Nikolay Konovalov. I'm a vice director of Burdenko Neurosurgical Institute in Moscow. Chairman of Spinal Department, also Jan's board member of Spinal Committee of WFNS. And Burdenko Neurosurgical Institute, I can say, is one of the biggest neurosurgical institutes in Europe, for surely in Europe, I think one of the third in the world. We have 300 beds only for neurosurgery, 20 ORs, and the number of the surgeries what we're doing for a year is 10,000 surgeries only neurosurgery. One part of this big institute is the spinal surgery. And now I'm going to share my experience about using my minimal invasive technique treating some spinal problems. So first of all, I want to start with the thing where I have a huge experience, more than 850 intermediate cord tumors. And I want to say that when you're treating intermediate cord tumors, you also have to use principle of minimal invasive surgery. Here you can see tractography, for which new standard of examining of intermediate cord tumors, and you can see now the quality of tractography, how tracks go around the tumor. You understand where the tumor is located. But I want to say about, for example, if we put example of this cavernous malformation, which is located on the ventral part of the spinal cord. So you can see from the dorsal part, you see any changes. So you have to split the spinal cord using minimal invasive principles, go through the spinal cord, and on the opposite side of the spinal cord, you can find this cavernous malformation, which have the episode of bleeding before, and the patients have some neurological problems, so we need to resect it. So we use also intraoperative angiography during cavernous malformation, but in real, it doesn't play any role in the tactic of the surgery. And run a little bit forward, and we resect this malformation, cavernous malformation totally. And you can see in front of it you can see in front of it, there will be an interesting thing. So the total malformation, total resecting, you see big vessel, which is in front. So the spinal cord total is split into two parts. And in front, we can see the vertebral artery. You can see it on our vertebral angiography. So after the surgery, you can see the patient, you see total removal of this cavernous malformation, and the patient doing very well after the surgery, no neurological deficit, and moving from our department in 4 or 5 days. So we can say if we follow the principle of minimally invasive surgery, try not to damage around tissue, we get very nice results even in treatment intermedullary cord tumors. Another example of minimally invasive surgery is a dural fistula. And most of the dural fistula, which we are doing in our institute, we do endovascular. But in this case, our endovascular colleagues cannot close this fistula because of some problems. And we need to do this by the microneurosurgery. So the first thing is very difficult to find the correct level. We're using with arm and navigation system. Then you open the dura and you see a lot of vessels, and you really don't know which to coagulate, where is exactly the dura fistula. But you have preoperative angiography here, and also you can use intraoperative angiography here, and then you can see immediately where is the fistula are. So the first goal is to find the correct level, then the second goal to find the correct vessel. And then the procedure after this will be already very simple. As you can see, I'll forward a little bit. The procedure is very simple. You just coagulate one vessel and cut it, and cut it. So, but you need to find the correct vessel, what to do. And after this, if you see intraoperative angiography, after this, you see that there's no already the vena fistula, and the patients get much better after the surgery than before, immediately. So to conclude this, I can say the most dural fistulas are doing by the endovascular surgeons, but when they cannot do this, you have to do some special means surgery to do them to correct this malformation. Surely the most minimal invasive way of treatment to spinal tumors is radiosurgery. In our institute, we have a huge center of radiosurgery, which includes Gamma Knife, Kyber Knife, Navalis, Turbine. And all of these 4 machines are working to help us in treatment of brain tumors and spinal tumors. For example, this example of metastatic lung cancer, which we didn't do any surgery for it, but we do radiosurgery, and you see nice nice MRI after the surgery and good clinical results. So most used for intermedullary cord tumors. The radiosurgery is good for metastasis because you can know the histology before, and if you're sure that it is a metastasis, sometimes it's better not to do the surgeries, go directly to the radiosurgery. Surely we have a special protocol to do the radiosurgery for extramedullary cord tumors, and one day I also can share it. Another way I want to tell you about principles of minimal invasive surgery for extramedullary cord tumors. Like this principle as keyhole approach. So the approach for this tumor is, you can see huge meningioma of craniovertebral junction, and the approach exactly like a size of the tumor. I don't know what is this red lines happening. So you see that the tumor is very big, and it's exactly the size of the approach is similar like the size of the tumor. In the most cases, we do debulking before, but in this case, we just try to remove the tumor in single piece. You can see how hard it's going out, but I don't know. Do you see this color lines on the screen? Okay, so you see the tumor was removed totally, but surely to start to do these cases, you see the small approach, no laminectomy. You need to be very experienced with open surgeries. So when you have very experienced with open surgeries, you can do the same with miss approaches. I have one question. I have red lines on my slides. Do you see them or not?
Yes, we do.
So I don't know. It's not from me. It's not from me. It's somebody who put it on. Can you? Because there was also yellow line that turned it off.
No, we didn't do that.
So
I don't know the reason. Yes, I see it for the first time, really.
Okay, so something. Okay, this Okay, better.
Yes.
One
Now,
more line. One more. So we have to say thank you to somebody. Thank you. Okay, we go forward. So, and you see, so a small cut from lateral part, and also we can say that these approaches for the extramedullary cord tumor is the future for the surgeries. And also, before we think that for some tumors which is located in front, now I think it's better to go with MIS because you can go more lateral and less stress the spinal cord. One more example of this is the patient after the surgery. As you can see, immediately activated and feels very good and go very short term home. This is another example of ependymoma of caudic. You see the big, rather big tumor, and we use the technique which we use for the stenosis quadrant, to muscle dilatator. Then we just drill intralaminar approach. And then we just do the same like we do for the stenosis. We reverse our like a Bernard Myers supposed over the top. We reverse our tube and decompress other side. And then you open the dura mater and you can remove, I say, or reproach at the same times like a tumor. So the tumor hardly go through the approach what we make. And the most interesting things that it give a great cost effect for the clinic, because patients go out, get up very fast, and in 1-2 days go home and just feel much better, much faster returning to work. There's most minimal invasive method for degenerative disease is now total full endoscopic procedures, which you can do is only a small tube with one instrument. I think everybody knows it. We have also a big experience using of this technique, but my main thing that you don't need to go directly intralaminar. You also can go transforaminal, which is different. And when we start to do this, we start to work with STOTS, with Joymax, and develop this technique. We think that the results will be much maybe better than using the classic techniques. And so this is the discriminations that we took out with this, and I'll show you one film, transforaminal approach. So main trick in this surgery, one of the main tricks in this surgery is to make a correct position. So you see, you can see you can see your endoscope is in. You find the sequester and you're taking it out. And here is the MRI before and after the surgery. You can see totally removed for disc herniation, and the cut is very small. But comparing our, so you can also do on the cervical level the same procedures we start to do on cervical level, but literature and comparing our results, we can say that a little bit less analgesic after them on the first day of surgery, on 2 days of surgery. Maybe the patients feel less local pain, but long-term results, according to the literature and according to our experience, is the same rate of complications, same rate of disc herniation. I think you can use both techniques, traditional microneurosurgery, which we do for most of the cases still in the institute because we don't have so much equipment for endoscopic, but we also do a lot of endoscopic surgeries. So this is, but the results, long-term results are the same. So this is also the question for discussion, and there's a lot of now papers which publicate the idea that the results are the same and what is the future development of these techniques. One idea of developing full endoscopic is to combine with the navigation system, because when you do full endoscope resection, you use a lot of fluora. And to increase the radiation on the spinal team, you use navigation system, and then you can place your endoscope already with using navigation system, which make much safe for the working team. So now I spoke much more about navigation systems and the interpretive CTs. The history of it, that navigation started to use in neurosurgery in early 90s. In 1995, first transpedicular screw was put in with the navigation system. And now we have one of the most powerful machine for this. It's Siemens Somatome Definition H. It's a 128 spiral CT, which is located in our operation room. And a very useful thing that we have one machine for 2 operation room. It's located in the garage in the middle, and you can use it, move it to the one part where the spinal surgeons are working, and for another part for brain surgeons. So in one part, they're doing brain surgeons, put stimulators, and do a DBS at the same time, and we use the same machine. Then we do examination for spinal surgeons to combine it with navigation system. And I'll show you some examples how we use it. For example, breast cancer, 53 years female. So we decided to do palliative surgery. We just do the fusion and partial removal, then radiotherapy. And you can see her laying in the CT before the surgery. And here is this how we do the scan. So the table going inside the CT, and CT moves on the table. They're both going inside each other. Then we do the scanning, and then we transfer automatically our data to a navigation system. And here how we work already. So you can see that the surgeons, this is the detail of the screen. But I have a small video which I made for the educational courses. They were primitive how the surgeon already working. He have to feel his hands, it's for sure. But he looking only at the screen, whereas his navigation tools are. But also I have to point out that there's no LED, there's no protection from the X-ray. So which makes the surgery much more easy. But you always have to look on the X-rays, but you have to trust your hands, because navigation, if you make mistakes, you'll be responsible for it. So you have always feel the tissue, understood they are in the bone, and then you'll be very successful. And this is the principles how you put transcutaneous screws. And here at the end of the one of the entire, when all the screws are implanted, and this is the final CT. We can do this quality of CT immediately after the surgery, already checking if all the screws is correct, all the decompression is did well, all the structures are decompressed, and we check all the screws, and then we are sure that everything is okay, and the number of reparation after this is coming less and less and less. Another example of a huge hardoma of the cervical. You can see here this big hardoma. You know the hardoma is supposed to resect it with end block resection. So, and we, first of all, we do preoperative MRI. You see the size of the tumor. Then we do angiography. Then we do biopsy, say that this is hardoma. Then we do 3D model. And because it's a huge resection of the bones, and we prepare a special mesh, which we can put with the screws, put inside when we resect the bone, or using 3D modeling. Then we do percutaneous tracheostomy, endoscopic gastrostomy, then posterior approach, remove all posterior elements, fuse the cervical, and not do C1, C2, and then C6 and C7, I think. We put, and then we do an anterior approach, and remove all the tumor in one block, and see, you can see the final pictures. You can see that the construction is very long. There's no connection with the bones of the head and the neck. All is on all is instruments. And surely to put all this construction in, you need to use intraoperative navigation and CT, because it's otherwise you can have a lot of complications. Another use of intraoperative CT, also we find out in navigation, even intraoperative CT, in correction of sagittal balance. For example, this woman who was operated several times in different clinics, mostly of the severe back pain because of the incorrect of sagittal balance. And we do PCO on her. So you see how she walks very difficult before the surgery and in incorrect balance. And during the surgery, we do PCO. And then using the CT, we decided which degree we need to correct the sagittal balance to put her in correct position. So you can see the plan of the surgery. And after we do the PCO, then we calculate the degree of correction using the CT. I can tell you that we do a lot of the surgeries, but we do some, and it's very nice when you can see on in one piece degree of your correction. and they can calculate it. According to some articles, the correction comparing to standard films is about difference about in 4 degrees. So it's quite accurate. So going forward, I have to say we have some experience using. First of all, we have experience of robots in spinal surgery. Now it's very popular, but we have first experience in 2009. At this time, we don't have any intraoperative CT, so we work with the CT. And so it was very long procedure, and really we don't like it because you need to first install the robot, then you have to combine with the preoperative CT, and then if you make some dislocation, then you can use it. But we still perform some cases with this, and it's you see percutaneous putting it with the screws using the robot, and also we did some fusions like a go lift techniques. But now we stop to do this. But our experience of using the robot, if it's usually you can use it alone. You need to use it also only with the CT. My main key to use all the navigation systems, you need to have an intraoperative CT or intraoperative arm or something like this. Because if you use preoperative CT, if you do decompression or distraction, or you put the cage in, you immediately your navigation system will be wrong. So the most important thing, because we now have 2 machines in the institute, it's one of them, it's a big Siemens, which is installed last years. And before we have OR, which was installed in 2013. So we have already 7 years of experience of using OR. And comparing with the Siemens, I can say, surely the quality of the pictures of the Siemens is better. But OR is much faster. And sometimes during your surgeries, you need to re-registrate it 4 or 5 times. And solely with OR, it's less dose of radiation, and the fast of registration 5 to 5 seconds. So in really, we can say that it's navigation in real time. If I feel that the navigation is not accurate, I immediately go out for 1 minute, we rescan, and go automatically all the data go to the navigation system, and then we are really navigating in real time. So this making this small, lightest machines much more useful than big machines, because I think it's the future. You don't need so huge quality of the pictures during the surgery like on Siemens, but it's more than enough to have arm or fast scanning machine, or that you can do more time re-navigation, and do the quality of the surgery is better. And according to the literature and to the data, if you're using navigation and if you're using machine intraoperative CT, the quality of your instrumentation is much better, coming to 99% of correction of putting of the screws. Surely nowadays we try to stop to put the screws, especially for stenosis. We now the tremendously changed, because the previous years, 4 years ago, we tried to screw everything. Now we try to not screw, not to do the screwing. We try to prevent instability and do micro decompression, and try not to damage bone structures, to take only the part inside the canal, to increase the canal and not to fuse them. And we do 1, 2, 3, 4 levels micro decompressions from like all over the top, and stop to do the fusions. And we changed our data, and now most surgeries for the stenosis on only micro decompression without any fusion. Surely there are some indications where you need to fuse. If you have spondylolisthesis more than 5 or 10 millimeters, or you have mobility than 3, 4 millimeters, or angel of facets more than 50 degrees, high disc, or high pelvic index, you need to think about the fusion. But we try to avoid it all the time. And so here is an interesting video. We make it by ourselves. It's a new, we try to make a digital atlas of spinal problems on a normal spine. This is Russian animation, which we make in our institute, in my department. And you can see here that it will be very interesting. I can send to all the students or to all the participants. Here you can see on 3D films, main principles of micro decompression during stenosis without any fusion. And you can see the quality of animation that Russian IT guys do. And then in the future, we want to develop and make the whole catalog of the surgeries, which you can show to the students or to the patients, to understand them how one surgeon is passing. Surely you can combine with the real videos, and it will be much nicer. I make it a little bit shorter, so it's look like this. And this is the steps of the surgery. And you see the quality of the picture, and the quality of the 3D reconstruction of the bone of all the structures is very, very high. So I think we together we can go forward and develop this atlas. So also important thing, what you can use navigation, you can navigate the cage. So you can put the correct angle, and it's much faster, and it's very easy. Surely experienced surgeons doesn't need any navigation to put the cage, but it's very also nice when you can navigate cages. For putting the screws, you use percutaneous screws. You put the CMCD needle and verto needle, so you can see from the skin where your needle will go, and where it will go inside the pedicle, and where will be the end of it. And so you can put the position of your screws in a very correct position. Another technique we will develop is the lateral interbody fusion, also using navigation system. For example, this case of spondylolisthesis, we put the patient lateral position. When with the neuromonitoring, we find the root, put the retractor, and then already we use the navigation system to put the cage. So also we don't use any fluora. We use also only with the arm to put this big cage from lateral part, make decompression, make a decompression. We're not opening the spinal canal, only do the decompression with distracting and putting the correct position of the vertebrae. And after this, we reverse the patient, and using also navigation system, put 4 screws from the back, for example. In this case, there's some more. But now we compare the results with the posterior approach or lateral approach, and according to our results, according to the literature results, long-term results are also the same. Those both techniques of putting the cages from the lateral part or putting the cages from the back part, to our experience and the experience of the literature, is about the same techniques. One interesting thing, for example, to doing cervical cases, now we use navigation drill. And how it looks like navigation drill. This is the case when we do laminectomy and we need to fuse the spine, and we use navigating drill. So it's very easy to put the screws using navigating drill. You just drill your direction. You can see the vertebral artery, you can see the nerve root, and you drill in the correct way with the navigation drill. And then you just tap and put the screw in. It's much, much faster than traditional things. Now for all cervical cases, we use navigation, especially we use navigating drill. So it's making your surgery much safer, much faster, and much accurate. Surely after this, we do control X-ray, control of CT, and check if all screws are okay. But you see this navigating drill, it's very easy. So you don't, and also when you're drilling, you don't move the bones much, and so you don't disturb your navigation, and you are correct with your navigation. So also for biopsy of, for example, the cervical level biopsy, it's very difficult to do without navigation. Oh, no, this is a hemangioma of T1 level. It's better to use the navigation intraoperative CT to put your because without the navigation without the intraoperative CT you can see how much cement you can put on in, because on the fluoro you don't see T1. With the navigation you put the needle exactly transpedicular in the vertebral body of TH1. And then you correct your position of your needle using the CT, and then you put the cement and immediately can see, because the machine is very fast, how much enough cement you put to embolize this hemangioma. You see nice results. Also another thing, cervical level, for example, biopsy of the tumor. It's very difficult to do with an intraoperative navigation and CT because you are very near the spinal cord, And here you can also put a tube exactly in the tumor, and even you can try to resect it a little part using some rongers. So you can see the biopsy, and after this biopsy, we don't need to do the surgery. We can pass out additional treatment. So interesting case, last case, what I'm going to show you, it's gunshot, and a lot of small bullets inside the spinal and spinal canal. Surely, if you do, you can do miss approach for this, because all the small parts of bullets you can navigate with navigation systems, go directly to this and remove it without not damaging the nerve root. So in the results, I think it will be better with this. So in my conclusions, I'm ready, finishing half an hour of talk. And the intraoperative navigation systems and intraoperative CT can be used in all spinal lesions. Reduce radiation experience on the surgeons, the surgical team. It's very important. It's real-time navigation, so you can navigate with fast machines very often and stay in real-time navigation. Very important control of decompression. You don't need any pre-planning. You can use your planning only directly in the surgeries. Post-operative CT control reduce the time of reoperations for big numbers. Decrease the surgical time, increase accuracy of surgical procedures. Technology is surgical supplement, not for substitutes of the skills of the surgeons. And I think the future will be navigation in the spinal cord tumors. Thank you very much. Thank you. I'm right on time, 30 minutes.
Yes, thank you. Where is Salman? Salman, are you there?
Okay, I turn off. So I need now to turn how can I go?
I think Salman has disappeared. So it was really very explanatory lecture. We have some questions. You can still.
I want to go to video, then you can see me. You see me now? You see my screen?
Yes.
What I have to do
your presentation can stay on the background.
Oh, okay, but I want to put my picture myself. You don't see me,
Okay,
yes?
okay. I can make it view options.
Okay, I think here. You can turn on the camera.
Doesn't matter.
Okay.
The question is, how do you close the dura during endoscopic surgery, and how do you treat CSF leakage after surgery if it happens?
Yeah, if damage, we don't close it. We don't close it because the approach is very small. The approach is very small. So if you have to damage the dura, you just take your endoscope off, and that's it. I just came from the surgery now. The guy was operating in St. Petersburg in another city, and he have no results after endoscopic intralaminar surgery. Now we do a reoperation on him. And when we open, my assistant opened it, he was very interesting. They see that there was the damage of the dura. The nerve roots was inside the wound, and there was no leakage of leakage of liquor because the wound is very small. So if you damage the dura during the endoscopic surgery, you just take my endoscope off, and that's it. You see my picture, or you see still my screen?
Yeah, we don't see your screen now. I shut your screen.
You see me, yes? Okay, thank you. You see me? Okay, good. I'm happy.
Another question is that, do you use navigation and monitoring in all spine cases?
Yeah, now I use Flura very rare. I use navigation in most of the cases. If I need to put screws, I use navigation because I have Flura only like staying. I have 2 operation rooms, and we use 3. So in 2 of them is CT, and 1 is OR. So most of the cases we use navigation. Surely I do some cases in private clinics where they don't have, when they don't have OR, but they do the same with the flora. The speed for me is about the same and the accuracy. But for the surgeons who are just starting, for my fellows, I think using of navigation system is very important. But surely they have, first of all, learn anatomical part and anatomical landmarks, how to put the screws. But then nowadays, all of them putting, for example, the screws using the navigation. And for me, it's very easy to control them, the quality of putting of the screws using intraoperative CT. So I think this is very important part.
What about monitoring? Do you use monitoring in every case?
No, we use the NERA monitoring obligatory for intramedullary cord tumors and use the NERA monitoring for some extramedullary cord tumors, ventral one. In that case, we don't use monitoring.
In deformities, what about deformities?
We don't correct a lot of deformities. We are neurosurgeons. Okay. So what I show you, this is kyphosis, sagittal balance. No, we don't do scoliosis. We don't do scoliosis. For deformities, we can do this. We have a very strong neurophysiological department, and we do D-waves, we do everything. But if we need it, we just immediately call them and they support us. Okay.
Another question is asking this: how do you measure the sagittal balance during surgery, perioperatively?
No, I have a young guy. Personally, me, I don't do this. I have a young generation who know how to correct them. They have all the figures, have all these modern computers, and they really involved in it. Personally, me, I just say me which niche I do the surgery. They say which angle you need to correct, then to be in correct position. And so this is it. That's it.
Yeah, I can give an answer. Yeah. Okay, I will do it. I think Salman is muted. Where is Salman? Salman, where are you? Another question is probably in addition to that sagittal balance correction level during surgery, new trend is to use pre-bent rods. Yeah. Actually, you can measure how much correction you will make, and
pre-bent rods.
Yeah. Yes, with the pre-bent rods, you can make it better way.
Now, for sure, I told you, we are more neurosurgical center. We don't have huge experience in correction of the sagittal balance. And so we do this if the people come to us, but we have very strong partners in orthopedic partners in the. This is Institute of Neurosurgery Center. We also have Central Institute of Orthopedic Surgeons. If I have some difficult deformities, I send to them, and they're doing them each day. So for them, they are very used to it. For us, our most is micro decompressions, microsurgery, tumors, degenerative disease. But deformities, we do them, but not too much. Not too much, because in economic part, we can't install a lot of screws because of the economic part. We do less constants.
Okay.
Mm-hmm. Okay, I'm back actually. Yeah, sorry, I got unmuted by mistake. Anyway, so there are a couple of things that, because there's a limit of 100 people, so there are many who couldn't connect, and some of them are messaging me with questions, and they're seeing it with somebody else's phone. Can you hear me, Nikolay?
Yeah, I hear you.
Yeah, so the couple of questions that they've asked is, what specific precautions you need to take when you do a spin with O-arm, and after that you're operating. If the patient moves while you're pushing or when using the drill, your accuracy goes up. So is there any special precautions that you take?
Yes, there's very easy. You have your instruments, and if you see that your instruments in not correct position on the navigation, if you put your instrument to the bone, as it's already under the bone or inside the bone, you have to renavigate. So the most thing is not the picture, it's your feelings and what you see in your feelings. If you see that there's some mistake between navigation and your feelings and your idea, better renavigate. And why I like to, for example, work more with the arm, because renavigation is 1 minute. It's very fast. If I have some problems with the Siemens, it's longer time. You have, you can do 4 times big CT during the surgery, spinal surgery. But with the arm, I can do 5, 6 times during the surgery, and it's very fast and very safe.
And what about the levels? For example, dorsal spine, when you're spinning, do you hold the breath or do you hold the respiration when you're spinning to make sure there is no problems afterwards?
We don't do this. It's okay. There's also some good idea. For example, if I do several level fusions, for example, screws cages, I go from the upper level. My frame is on the bottom, and I go to the upper level, put upper screws, then cage, upper screws, cage. So I just distract from to upper part. So I don't need to recalibrate after each procedure. So we can do in one shot, if it's good, and if we are lucky, we can do in one shot 3-4 levels, decompression and fusion, without any renavigation. But if we see some mistakes, then we do this.
Okay, another question was regarding your closure. What specific thing do you use for your closure when you're doing MIS, for example, C-spine, and you get a leak? Is there any specific closure clips or anything?
60 sutures. And we also use tachocomp and glue. And so, for example, we have a lot of problems because sometimes I have removing big tumors, which is damage all dura. And then we just do, for example, we try to close the dura or put some synthetic dura over it. Then we put tachocomp, glue, and tachocomp. It's a sandwich. And in the closing of MIS, we use suturing with a microsurgical technique with 60 sutures, and then we put tachocomp. That's it.
Okay. What about there was when you're doing over the top? You're showing the over the top MIS decompression. Is there any specific drill you use that inhibits the problem with dural tear or something?
This drill I showed to you, we don't use it anymore. We use a long diamond drill, long 2 or 3 millimeters ball diamond drill. The key to the over the top approach is to drill bottom part of the spinal process. When you do lateral part, then you drill the bottom part of spinal process, make a space for you to go on the opposite side and drill as much bone as you can from the bottom part of spinal process. And then you can easily, there will be space between dura and the bone, and you reverse the patient a little bit, and then reverse your tube and go on the opposite side. And then you see the same like a laminectomy, but a little bit from the side. So the key for drill the bottom of the spinal process.
One related question. If you do not close the dura in most of the instances, you said so.
No, it's for the endoscopic cases.
For the endoscopic cases. Do you see any pseudomeningocele?
It can be. It can be. Not much, but it can be. But because we don't cut the muscles, we only puncture it. The muscles prevent it. So there is no approach really. There is like they can be a little bit around it, but there's all the tissue because the tissue is not. So in the most cases, it's like this. But if it doesn't cause any problem, it's nothing.
Okay. There is another question regarding the lateral approach that you showed, putting in cages laterally. What is your complication rate regarding weakness in the thigh in these patients?
The same as in literature, but now the same as in literature nowadays. For example, because when I start to do these techniques, I prefer to do everything from posterior. For me, it's much faster to put the tube, to take the facet off. 2 minutes to put the cage. I think the same level of correction will be the same correction, and to do everything from behind. It's my experience. I prefer now to do this because really, in the cases of doing a lateral approach, there's a lot of foot drop after the surgery and some complications. It's the same to the literature. But for me, in everyday life, I prefer to do, for example, like if I do the disc herniation, I prefer to do microsurgery with the tube. It's much faster, and I'll be 100% sure that I did everything correct because I see all the details. In the endoscope, you don't see all the picture. You feel that you do this, but it's different from micro. I think the results are the same. For me, it's better to go with the microsurgery technique for disc herniation. And the same for if I need to do the fusion, I do from posterior. I take the biggest case as I can. And I think it's not big advantages to doing lateral approach. I think it's a little bit make the time of the surgery a little bit longer.
Okay, and what about, have you tried the oblique approach trying to avoid this complication?
We only want to do this this approach that I show you.
Okay. All right, okay. And where do you see the future of MIS surgery itself?
I think to do less fusion, which now we see much better results really on our patients, especially in old people, for the decompression on multi-levels, less screws, and to the future, I don't know. This is very difficult. If you know the future, I'll be ready to start to do this. But I think the navigate positioning of your cut, minimize the cut. Don't do this too minimal, because if you do too minimal, you don't reach your goal. You don't decompress well. You don't reach your if you make 1 centimeter small cut, but you don't do good nerve decompression, you don't reach good results. And so you have to not to be too minimal and not to be too aggressive. You have to find the gold middle of it. I think this is the future.
Okay, and what about robotic surgery? You know, you touched it, but the question is, do you think robots with their accuracy will take over the medical schools that we are putting in at the moment? And do you think their accuracy is going to get better and we will have less complications with robotic surgery?
I'm following this subject because we start, as I told you, to work with the robot, and now I think there's no evidence base that putting the screws with the navigation system, with freehand navigation system or robotic navigation system does give any clinical results, because the accuracy, more surely the robot may be more accurate for 1-2 millimeter, but it doesn't play a role of putting the screws. I think the accuracy with putting a navigation system is the same with the robot. A robot only show you the way, the guide where you can to drill, but it's not so important, I think. But because now all the machines like a Medtronic also make a robot, Brain Lab making a robot. Brain Lab robot is only the hand that can position your trajectory of your drilling. I think there's no big advantages, but there also was not big advantages when we start to use first navigation systems very, very long time ago. When we bought the first station 7, I think it was very difficult to use it, and we see not any usage of it. Now we don't do any surgery without the navigation. So we need to be in the step of developing, and then when the future will come, we'll be in and not out.
So are there any surgeries in which you won't use navigation? Any kind of surgeries?
We use it everywhere. Most thing what I love it is I have less radiation. I don't radiate myself, and I don't put the lead. I put the lead on the lead protection only in the case when I put cement in. That's it. And I hate to put the lead.
Okay, I think there are 2 last questions here. One is regarding, you said that you leave the door open and you just use the triple layer closure. The question is, doesn't the patient have low pressure headaches afterwards?
Sorry?
When you have CSF leak and you repair, and post-operatively, do they have low pressure headaches?
No. It's like removing all the tumors. No, the headache becomes when you have a block of the circulation of the liquor. For example, if a chiari malformation or like a big tumor on the cervical level, and when you take this compression off, and then before the patient starts to well, sometimes have a headache. But no, if you damage the dura or you open the dura for the extramedullary cord, intramedullary cord tumor, never headaches after the surgery.
Okay, and there's a last question. What about the developing countries? Can they afford this price of this, all this O-arm and this hi-fi stuff that you're showing? And is it really worth it people spending all that money in the institution like this?
I can say that for example, I do the surgeries, for example, in different position. When I do in private clinic, we don't have any OR there, and I do the same levels of surgeries only using the classic fluoride. Surely there is some advantages of this technology. They are very expensive. Like it's 100%, and you have to use make more expensive your surgery. But we have good government support. For example, now I think we're going to buy our second arm, new version of arm. And if government supports you, surely it's not for a private clinic, because for private you can't get money from it. But for government clinic, if you go work a lot, I think it is the future. And really, the main key to use the navigation is to use it all the time. If you're using it only for the difficult cases, then because there's a lot of mistakes in navigation, there's a lot of tricks. You have to learn on simple cases, and then you can switch to difficult cases. Because, for example, your team, if you put navigation in only in difficult cases, are not used to use with this. Our nurses already know how to put all this stuff, which case to open, which frame to give us, to clear all the spheres, and they know everything. They know how to register the instruments, and it's really working very fast now. So, but if you have to do this every day.
Salman,
okay, so yes,
I can make a comment on that question.
Sure.
Actually, the minimally invasive surgeries have mainly three disadvantages. First one is the basic instruments are quite expensive.
Yes.
Second, the training time is steep. Actually, you must get a good training on that. Third thing, you probably are getting more X-rays to yourself.
Yeah.
By using even with navigations. For instance, in CT scans, if you are doing intraoperative CT scans, you get too much X-ray there. You must be out.
Yeah, we're always out. We're always out.
Yeah.
I think,
but the advantages, the main advantage is that you can make even a day surgery, very restricted duration of hospital stays you can provide. Patients are more comfortable after surgery. And third thing is less infection you are having. There are very nice series that are showing in the outcomes, they are having less infection rates. These are the main advantages and disadvantages. You then will decide according to your budget and to your personal other things, whether you have to start a minimally invasive surgery or not.
And also, I can say that to start minimally invasive surgery, you have very experience in regular surgery. After when you have a big experience in regular surgery, then you can go minimally invasive. Not at the beginning. You have to start with the regular surgery at the beginning.
Another thing, I think for the training, you need almost always you need some cadaver dissections.
Yeah.
Or cadaver applications of minimally invasive surgeries. Otherwise, it's the learning, during the learning time, you can make too many mistakes. Yeah, then you will get frustrated and leave all the things out.
Absolutely.
Yeah, I think the other thing about learning curve is that, there's learning curve for your basic surgical skills, and there's learning curve for MIS and how to make sure that you don't cause complications. And then obviously there's a learning curve for navigation. So all these learning curves have to be taken into account. And probably the best thing is to spend some time with a mentor somewhere, or probably in a center where lots of these surgeries are happening. If you want to be very good at it, and you want to make sure you don't cause problems to your patients whenever you start doing that. Nikolay, you want to give last comments, and then we get Mehmet to say a few things and we wrap up?
Yeah, I want to thank you for inviting me, because it's my first Zoom lecture after the starting of COVID. And I really think it's the future, it will be in this Zoom lectures, because It's really, I don't need to fly to anywhere. I just get to operation room and I now can go back to my patients. And I think the level of the communication is very high. It's very interesting. And I see there's a lot of participants, about 100 participants. And I'm very happy that they hear me. I'm very happy to share our experience. And I think the future, surely it's very nice to meet together and just be in the meetings. But I think it will be less and less, but in future. But this way of conversation, I think, is not so bad. It's not so bad and very easy to the people to go inside of it. They don't need to buy the tickets. They don't need to fly. They can just turn on their computer in a very cheap way to get the information. And we can very glad to share this. Thank you very much, everybody.
I thank you, Nikolay. It was a really very, very attractive presentation and lecture. Although this type of meeting, webinar meetings, are quite successful, and we are probably somewhat at least recovering from our anxiety and lack of motivation in those COVID-19 outbreaks. But we are humans, and then we cannot do it this way. I think at the end we must shake hands, we must drink something, and we must go to dinner. But I'm very grateful for your lecture and also for contributions of Salman. Thank you, everybody, for joining us and becoming with us.
Thank you very much, Mohammed. Thank you.
Thank you.
Thank you.
Goodbye.
Thank you, everyone. It was wonderful. Thank you, Mehmet, for organizing it. See you, Nikolay, soon.
Bye. Bye. Thank you.
Okay, bye-bye.